much. Good evening. Can you guys see this shared?
Yeah, we can all see it, Rik.
Okay. So while Professor Holtz is just getting his presentation together, I thought just in the interest of time, we'll continue with the other talk. I'm just going to talk very briefly about Autocot versus other procedures. So where this procedure would fit in and a comparison of alternative procedures that we've used historically and currently in relation to cartilage defects. So we'll go through the just brief mention of the treatment algorithm and where Autocot would fit in. And then these are the other alternative techniques that I'll briefly mention as alternatives to Autocot that we've used in the past. So the treatment algorithm basically splits into three sections, and that's dependent upon the size of the defect. So that's we've used a cutoff of around 2.5 normally in distributing these. And then each defect is split into what depth is involved, so whether it's chondral or osteochondral defect. So for the smaller defects, we've used OATS in the past for osteochondral, involving the whole subchondral unit. If it's purely chondral, then we have used microfracture or variants of in the past. And then for the larger defects, this is where it's been more sort of allograft and cellular-based techniques. So not just simple microfracture or scaffolds alone. And it's really in these larger defects, so the medium and the larger defects is where Autocot would fit in, and certainly does it in my practice. I also use Autocot in these smaller, predominantly chondral defects, certainly from 1 centimeter and above, but less than 1 centimeter, I would still do a combination of drilling techniques, so something like nanofracture rather than microfracture, just getting deep, thin channels into the subchondral bone, but that's reserved for smaller defects, so less than 1 centimeter. So we mentioned microfracture. So microfracture is a technique we all know. I won't spend too long on it. The advantages, of course, are that it's single stage, inexpensive, and relatively straightforward, and we've all done this. But whilst not technically demanding, of course, the technique itself does have some nuances, and we need to make sure that we're getting vertical walls, exposing the subchondral bone, so taking away the white calcified layer, and then creating these channels. So this is where I think nanofracture is of more benefit than microfracture, because there are issues with problems of the subchondral bone, and this is partly why microfracture tends to fail after around 2 years, because of developments around the subchondral bone in terms of interlesional osteophytes and improper cartilage formation at this zone. Of course, microfracture creates a less durable construct. It creates a fibrocartilage construct, and the biomechanical properties of that are not the same as articular hyaline cartilage. So in terms of how we can make this better, so Behrens developed the AMIC technique, the autologous matrix-induced chondrogenesis technique. This classically used the chondroguide tissue, which is a bilaminar construct, to try and ease integration of the cells from the superclot and to contain them within the defect site. So this was developed really to stabilize the superclot and to try and improve healing of the defects. The advantages of this, of course, are that it's still single step and it's much cheaper compared to two-stage cellular-based techniques. But again, this tends to create more fibrocartilage type defects, healing rather than hyaline-like. So for the deeper defects or the slightly larger defects, of course, there's the option of osteochondral grafting. Various options in this. We can use autograft, allograft, and of course synthetic grafts with varying results. The advantages is that single stage. We tend to get more hyaline-like response from these techniques, as it does also address the whole osteochondral unit. There are issues, donor site morbidity particularly, tissue availability for larger defects, where we then have to turn to the massive osteochondral allografts. It is an expensive procedure, small risk of infection, but graft availability, as I mentioned, particularly with the allograft tissue, is very limited in most parts of the world, and certainly this side of the world. So there are these synthetic options. This is one option. This is a trilaminar construct, again, which this is equine origin. So this is quite readily available, but it does require quite deep preparation of the defect site to implant this. In terms of the results of osteochondral grafting, uniformly quite good, actually. 90% plus good outcomes are looking at the various scores, so things like KOOS and other activity scores, 90% plus outcomes. Defect size, you can see most of the studies here using a defect size of just over 2 centimeters. So these are for medium to large defects, achieving quite good results with osteochondral grafting. So ACI, Professor Holtz did mention ACI earlier. So this is a cell-based technique, again, varied availability around the world, but certainly very, very expensive, 2-stage. And there are issues with graft hypertrophy in particular with the 2-stage ACI techniques. And certainly in the UK, where I did more of these, we did see this quite a lot, and we ended up doing a lot of 2nd-stage procedures, arthroscopies, debridements, and so on. So it even then became a 3-stage procedure to treat these patients. So adding to the expense and the morbidity for the patient. So the ACI is not without its problems. But overall, the quality of repair tissue obtained is very good, so it's Highland-like. So then the single-stage cell-based techniques. This is one option predominantly in the US. This is particulate juvenile morselized cartilage. I don't think it's available outside the US, actually, because of very, very small volumes. So I've got no personal experience of this, but this is just something to mention as an option that it is available, but mainly in the US. Very, very expensive, over $20,000 for one implant, but very limited availability. So a more widely available single-stage option is indeed Autocot. So autologous chips have been used in the past, starting with Albrecht in 1983, various animal studies, and then a couple of clinical studies, Christiansen, and then by Guian Salzman and his team in Switzerland more recently. So Guian's team published the results of 27 patients. So you can see the defect size is actually quite large, 3.1 centimeters, and followed these up for 2 years. They achieved an overall 92.6% satisfaction rate with these defect sizes. And you can see that the results of this study very closely mirror the earlier systematic review results that I showed you regarding osteochondral grafting. Again, 90% plus patient satisfaction with these large defect sites. And we're currently doing a prospective multi-center study looking at the outcomes of Autocot in Europe and the Middle East. So we're currently recruiting and hope to report the results of that from the end of next year onwards. Looking at both MRI, clinical, and histology. So some useful results coming in the future. So viability, there has been some question in the past as to whether these autologous cartilage chips, particularly taken from the defect site itself, maintain cellular viability. So there has been some work done in this, and you can see the results. So the percentages are maintained in terms of both viability and proliferation rate of the chondrocytes, and these are intralesional autologous cartilage chips. So we can be fairly confident that these are biologically active chips that we use. So I'll mention this briefly because I'm sure Professor Holtz will go into this in more detail. But Autocot, essentially what we're doing with Autocot is we are addressing all 3 aspects of the healing triad to get cartilage healing. So we are addressing the matrix, providing cells and growth factors to the mix to try and encourage healing. So the cells, of course, come from the patient, their own chondrocytes from within the lesion and from surrounding areas such as the supratrochlear region, the intercondylar notch, where we can harvest these. The matrix is the patient's own cartilage, together to form a matrix. The growth factors are obtained from the ACP. and then this is fixed using the soft tissue matrix obtained from the thrombinator along as autologous fibrin glue, which then helps to hold this construct together. So these are the kind of defects that we can treat. Full thickness trochlear defects, which are then grafted and achieving nice uniform fill. So in summary, as with any cartilage procedure, of course, whilst we can go through the various techniques, but it's very important that we don't miss anything. We need to address any issues of malalignment, ligament laxity, and of course meniscus deficiency to optimize our outcomes for these patients. Each patient definitely needs an individualized approach for this. We can't really be so didactic with indications because we have to take into account characteristics of the lesion, as I've mentioned, patient factors as well. The patient must be compliant with the rehab, other patient factors such as if they're a smoker, if there are multiple comorbidities, and of course surgeon factors. The surgeon has to be proficient in the techniques. We need to have an awareness of the pros and cons of the different techniques in order to make the right choice. And as I briefly mentioned earlier, there are studies ongoing, but definitely we need further prospective collaborative work to look into the outcomes of these treatments.